Hello, my name is Christy Holshouser, and I want to welcome you to this presentation of Emergency Department Nursing Initial Patient Assessment. Today we're going to talk about the specific assessment of the patient as they come into the emergency room and how we will work through that assessment from a head-to-toe perspective. There are two components to the emergency room assessment. There's a primary assessment and a secondary assessment. But as we begin, let's look at just a few things that kind of give us an overview of how we should approach the assessment. So the assessment is systematic and it's organized in how we go through the assessment of the patient, because we want to be able to pull in the information that is pertinent to the specific situation that's going on. In the emergency room, we're not initially looking at all of the family history, all of the patient medical history. When they first come in the door, we want to focus primarily on what that initial cause is that brought them to the emergency room and be able to then determine how to prioritize our care to make sure that the patient gets the best care that we can give them. So we want to organize and look at the specific life-threatening situation that brought them to the emergency room. We want to identify the injury. What specifically is going on? Did they break their arm? Do they have a laceration? What's that specific injury that they're coming for? And then again, prioritize that care. So we'll look at this in a primary assessment and secondary assessment approach. The primary assessment is used to identify that life-threatening situation. What brought them here? Why did they come in the doors? And then the secondary assessment will be used to look at any other injuries that they may have associated with that initial injury or that significant injury, and then we'll also from there be able to look at their medical history, their family history, surgeries, and so forth, and be able to bring in all of their history to better care for them. So with primary assessment, we have 4 components, and between primary and secondary assessment, you'll see that they go in alphabetical order, so it can make it a little bit easier to understand. So with primary assessment, first we're going to talk about airway. Second, we'll talk about breathing. Third, circulation. And then fourth is disability, or what we look at when we're talking about neurological deficits, things that would cause that patient to have a disability, whether it be considering a stroke or a head trauma, some type of a neurological deficit. With primary assessment, we'll begin with the airway, and with any emergency room patient, we want to make sure that we are maintaining cervical spine stabilization. And that comes primary, even with all of the other components that we're going to talk about, specifically with the airway, because as you manage the airway of the patient, you may have to move their neck in certain positions to be able to get an airway in. So we want to ensure that their C-spine is stabilized so that we don't cause any further damage. That patient may have come to the emergency room because of a car accident. They may have had a fall. So not knowing initially all the background information, we want to make sure we maintain that C-spine stabilization. So with assessment of the airway, I first want to know, can the patient talk to me? If the patient can talk to me, then that gives me a lot of information to know how well they can breathe. If you can't talk to me, then you probably aren't being able to breathe very well. Also with airway, we want to consider, is there an obstruction? One obstruction could be the tongue. Maybe the patient has had an insect bite or a bee sting that they're allergic to, and now their tongue is swelling because of anaphylaxis, and that tongue can get in the way of being able to breathe appropriately. Also, we want to consider, have they lost any teeth? Maybe the patient was in a fight or a car wreck, something that involved trauma to their face, and they've had teeth to become loose or be knocked out. Are those teeth getting in the way of the airway? Have they aspirated teeth? We also want to consider any type of foreign body. Foreign bodies are very common with little children, and maybe you have the 3-year-old that was chewing on a balloon and that balloon burst, and now part of that balloon is down in their airway. And then also edema. And edema can be, as we were talking about with the tongue being swollen, but if you have head trauma or neck trauma, maybe they're having swelling in their neck and that swelling is pushing in on their airway. So we always want to consider, is there some type of an obstruction in the way that is hindering their breathing? Also, we want to consider, are there any secretions? And secretions can come from multiple reasons as well. Two that we think about specifically are blood and vomitus. Maybe the patient has a large injury to their neck and now there's blood in their airway and they're not able to breathe appropriately because of that blood. Or maybe they had abdominal trauma and they are vomiting frequently, and as they are vomiting, that vomitus is going back down into their lungs and causing trouble with their airway and giving them the inability to breathe well. So as we consider the airway and we look at causes and trying to identify what is the problem, why is this patient not able to breathe well, then we want to consider our interventions. With interventions, we want to, first of all, make sure that we have a patent airway. If the patient doesn't have a patent or an open airway, then they're obviously not going to be able to breathe well. So in intervening to maintain a patent airway, initially, as we said before, you want to maintain cervical spine stabilization. We don't know all the history of what has happened as to why this patient has come to the emergency room. So we want to make sure that we maintain their C-spine stabilization so that we don't cause any further harm. We also want to maintain a position that does not compromise the patient's airway. An example for that could be a patient with asthma or COPD. Those patients, when they come in with an acute flare or an exacerbation, they may be seated in a way that helps them to breathe more easily. We consider that sometimes what's called a tripod position. The patient may be sitting on the bed and they're leaning forward to help open up the airway, to help open up their lungs, to be able to get better breathing, so that their breathing is more comfortable for them. So if the patient has put themselves in a position that is more comfortable, we want to try to maintain that comfort level, also maintaining the airway and not causing any compromise to that airway. So as we look at airways, and we're looking at specifically an obstructed airway, we need to know, is it partially obstructed or is it totally obstructed? So we want to place the patient in a supine position, and then we again make sure we stabilize their C-spine, and then we want to open the airway. So if the airway is partially or fully obstructed, we need to be able to get in there and remove the obstruction. Some ways that we open the airway are through a jaw thrust, through chin lift, and as we do that, as you are pulling the jaw forward and lifting the chin up, that helps to pull the tongue off of the back of the airway and helps to open up the airway so that we can see, is there a foreign body in the way? Is there some type of obstruction? And if there is, can I see it and be able to get to it? If I can see the obstruction, then I can reach in and remove that obstruction. If I can't see it, then we may have to move on to more invasive type procedures to be able to look further down into the airway. So with positioning the airway, jaw thrust, chin lift, and be able to look and see what is there. If the obstruction is secretions, then we can use suctioning to help remove those secretions. With suctioning, we want to make sure that we don't induce the gag reflex. If we induce their gag reflex, then we may produce more secretions. They may vomit, and then you have those secretions to contend with as well. With an obstructed airway, partially or total, we may have to intervene with placing an airway. Some types of airways that we can use are oropharyngeal or nasopharyngeal. An oropharyngeal airway is an airway that goes in through the mouth. Nasopharyngeal goes in through the nose and goes back into the trachea to be able to open up that airway to provide for good breathing. We also may have to use bag valve mask ventilation. What this is using an apparatus that has a mask with the bag that is connected to oxygen, and we are able to breathe for the patient. The mask is placed over the patient's face and we inflate, deflate the bag to help the patient to breathe. If those procedures or interventions are not working, we may have to proceed to endotracheal intubation, and that is where you place a breathing tube into the patient's airway to be able to get direct access into the lungs and be able to bypass any obstruction that is there. There are two ways that we can intubate or place an endotracheal tube. That is through the mouth or through the nose. Again, either way that we are working with the patient's airway, we want to make sure that we maintain that C-spine stabilization. If we are having to intubate the patient through their mouth, we have to be very careful with moving the neck. With our jaw thrust, our chin lift, we may not be able to do that. We may have to use another approach to be able to get the breathing tube into the patient's airway. With endotracheal intubation, it requires a second person to help maintain C-spine stabilization. Now, this is a procedure that a physician would do. The nurse is not going to be intubating the patient, but you as a nurse, you may be asked to help maintain C-spine stabilization so that that physician can intubate that patient appropriately without causing damage to their cervical spine. And then the second way to intubate could be nasally. Now, there are some contraindications to intubating someone through the nose. Those contraindications include if the patient is apneic, if they have any mid-facial fractures, if they have any basilar skull fractures. A basilar skull fracture is a fracture that is through the base of the skull, thinking about in relation to the nose area before you get down into the mouth, the bones that run through the base along where the nose is. If there are basilar skull fractures, when you intubate a patient or you put anything in through their nose, you run the risk of that breathing tube or potentially that nasogastric tube going up into the brain instead of going down into the airway. So if there are basilar skull fractures, you will not want to intubate the patient through their nose. And then you also want to know if there's any frontal sinus fractures. If they have fractured the bones across the front of their face, then you would not want to intubate through the nose as well, because the apparatus could go to the wrong place and not correctly go to their airway. The last way that you can provide intervention for their airway is through cricothyroidotomy, and that is where you place a tracheostomy tube. You make an incision into the neck, or the physician would make an incision into the neck and place a breathing tube actually straight into the trachea, and that patient would then have a tracheostomy tube. So as we continue on through the primary assessment, we've talked about the airway and how to assess that the airway is patent and the importance of maintaining that airway. Second, we want to look at breathing. If we have an appropriate established airway, that isn't going to help us in the long run if the patient isn't breathing. So we want to then proceed on to breathing to see how well that patient's breathing. Are they meeting the requirements that their body needs? So with assessment of breathing, we want to consider any life-threatening conditions. Those conditions can include penetrating injuries to the chest, blunt chest trauma, acceleration injuries, deceleration injuries. So when we think about penetrating injuries of the chest, it can be any type of penetrating injury. It can be a knife into the chest, it can be a gunshot with a bullet that has gone through the chest, some type of impalement, a large piece of wood has gone through the chest, anything that would penetrate through the chest wall. Blunt chest trauma can be, some examples of that can be if the patient is in a car wreck and their chest hits the steering wheel, or the patient is on a motorcycle and they are hit by another vehicle and they are thrown into that vehicle and they have blunt chest trauma. That can affect their breathing as well. So other life-threatening injuries are acceleration, deceleration injuries. You think of the patient in a car wreck. The car is moving, their bodies are moving, and the organs inside your body is moving. So when that car comes to that abrupt stop, when it has hit that object or that object has hit the car has stopped, but your body is still moving. So your body moves until it stops, whether it stops by hitting the steering wheel or whether it stops by hitting the windshield. And then as your body stops, your organs are still moving, and then they stop. So you have this multiple trauma that's happening to your body. The outside of your body is injured by the surrounding obstruction that you've come in contact with, and then your organs are hitting your body. And then as everything goes forward and stops, you have the same in reverse. So your body is thrown, potentially their body is thrown back into the car seat. Now their body has hit the car seat and their organs have come back and hit their body as well. So you have this acceleration, deceleration injuries that can occur that can harm the patient in multiple areas, the brain, the lungs, the heart. So when you're considering what caused the accident, what was the mechanism of the injury, that will help you to understand, are there acceleration or deceleration injuries involved. So when the airway is secure and we know that we've established or maintained a patent airway, then we can proceed with the breathing assessment to ensure that they have breathing that is adequate to meet their ventilation needs. So first we want to consider, do they have spontaneous breathing? Are they able to breathe on their own? Or are we having to help them with potentially a bag valve mask ventilation? Can they initiate that breath and keep that breath going to meet the needs? We also want to look at the rise and the fall of the chest. When you think of blunt chest trauma, something hitting the chest, when you take a breath, both sides of your chest should rise and fall symmetrically. If they do not, then you have to consider, did that chest trauma injure ribs on one side? You think of a flail chest that could come into play where ribs are broken on one side, maybe high on one side and low on another side. And the patient takes a deep breath, one side may rise, but the other side may not come up equally. That is important to consider when we are looking at adequate breathing. We also want to consider their respiratory rate and pattern. Are they breathing too slow, too fast? Those give us information about what is going on with the patient. Do they have injury specifically to chest wall structures? And we've alluded to that already, talking about broken ribs. Is everything intact? Is the sternum intact? Are the ribs intact? Are they having to use accessory muscles? We think about accessory muscles when we are talking about retractions that the patient is having with their breathing. Use of accessory muscles can include the muscles up along the shoulders and the neck area, or also the muscles around the abdominal area. If they are really struggling to take that breath, and you're seeing that they're having to use all the muscles that are involved around the chest, that is not normal with normal breathing, then you have to consider any type of other damage that's going on. So do they have bilateral breath sounds? Can you hear breath sounds equally on both sides? And not just both sides, but down through the lung, through the different lobes of the lungs. Can we hear breath sounds throughout? We also want to consider their jugular veins. The jugular veins are found in the neck. With respiratory injuries, if they're not able to breathe appropriately, that then in turn affects the heart, and the heart can't function as well. And you can see distended neck veins that are a result of things not functioning as they should. And then also we want to consider their trachea. When you look at a patient that has not had trauma, your trachea is in a straight line. In a patient that's had chest trauma or potentially airway trauma, that trachea may be shifted over to one side. So you want to see, is the trachea midline, or if it is out of place, is that what's causing the airway compromise? Now with breathing, we want to consider interventions that we can employ to help the patient. First, we want to look at interventions with effective breathing. So this is a patient that's able to maintain the breathing on their own. They have spontaneous breathing. We are not having to use a bag valve mask ventilation. We've not had to insert a breathing tube, but this patient has effective breathing on their own. For them, we would administer oxygen, and you can administer oxygen in multiple ways. You can use a nasal cannula where the cannulas go into the nose, the oxygen is delivered that way. You can use a variety of masks for patients to deliver oxygen. But we want to administer oxygen at a rate that's adequate to meet their oxygen needs and in a way that will help them to maintain adequate oxygen CO2 exchange. So a way that we can do that, one apparatus is called a non-rebreather mask. And that's a mask, obviously they have the mask on, but as they breathe in the oxygen, it helps to dissipate the CO2 as well, so that they're not rebreathing their own CO2 and making their risk for acidosis to increase. So with a non-rebreather, we want to ensure that the bag inflates. so that it is working appropriately. And we may have to increase the oxygen to 12 to 15 liters per minute. And that will ensure that the patient is getting adequate oxygen for their needs. For ineffective breathing, this is the patient that is not able to maintain spontaneous respirations. Then we want to find out why they're not able to do that and then intervene to fix those problems. So maybe it's a patient that has altered mental status. Maybe they are not able to either breathe on their own or not able to maintain their airway. We want to look at, is this patient cyanotic? If they are cyanotic, why are they cyanotic? Is there ineffective breathing because of asymmetric chest movement? We've talked about that already. Do they have a chest wound? Is there a bullet sitting in one of their lungs? Do they have a penetrating object going through their chest? Do they have a tracheal shift? That would cause ineffective breathing. Distended neck veins, and then altered breath sounds. Those are all assessment areas that we need to look at that give us direction on how to intervene for that patient. Whatever the problem is that we see, we need to try to intervene to fix that to ensure that they have adequate breathing. And then the last is absent breathing. If there is absent breathing, then obviously we need to intubate that patient. We need to place an endotracheal tube and breathe for that patient so that we can maintain adequate ventilation perfusion so that they do not have further damage to their brain, to their heart, and to the other parts of their body. And then some things to consider with breathing is life-threatening conditions that affect breathing. One of those is tension pneumothorax. Second is an open pneumothorax. We've already talked about flail chest, where ribs are broken and the chest is not rising symmetrically. The next could be pulmonary contusion. This happens with blunt chest trauma, where the lungs have had injury to them specifically and there are hematomas or bruises to the lungs. And then also consider hemothorax. Hemothorax is where there is blood in around the lungs. Pneumothorax, there is air in around the lungs. So these are all life-threatening conditions that can affect breathing and make it difficult for the lungs to function appropriately.